So I've been at other workshops and fora where, as Jacqueline Beagle told us, her institution is really footing the bill for all of the testing and really the very refined patient care that patients are receiving. And as Martin has told us, the insurance companies just don't want to pay for anything unless they have to. And so we're kind of in a time period where they're basically saying, show us the beef or show us the data. And even though we know in our hearts as clinicians or people who are even looking at populations that we're likely to be able to identify a benefit, the issue is it a small number of people who are going to likely benefit from our weeding out, among many thousands? Or is it going to be a large number, and how can we decide who we do the test on? So I think, as I alluded to, the cost and the equitable aspects of this, I think, are really challenging. Cost to the people who are trying to deliver better care, to do precision health or precision medicine, personalized medicine, and then to us as a society looking at how expensive our healthcare already is, and if we add genomic testing, that isn't really indicated, how does that do in terms of the pocketbook? So I'd welcome some questions from the audience. Yes.
Hi, I'm Tony Schiff. I teach health law here at UCLA. Let me ask you a question, Dr. Zagari. This is a conceptual thing. If there's a lot of talk about the insurance, about, frankly, pharma taking some of the risk if a treatment failed. Is a general concept, if a pharma company were to look at that imposition of risk placed by the insurance companies, what type of screening would you recommend that a patient, what kind of screening would the pharma company then ask a patient to have in order for them to assume the risk of a failed treatment and not be paid by the insurance company?
Mm-hmm. No, that's a great question. So we're actually exploring, how many people here have heard of value-based healthcare? Mm-hmm. Exactly, it's everywhere right now. It's value-based pricing, value-based contracting, value-based healthcare. Amgen actually is one of the companies a bit on the forefront of that. We have upwards of 25 agreements in the U.S. that we're categorizing as value-based healthcare. The one that's gotten the most press and sort of the most press because Harvard Pilgrim actually sort of agreed with us that this would be a good thing to talk about from both sides was our agreement with Harvard Pilgrim. So I think that, and that's not an accident. Harvard Pilgrim actually is one of the more integrated plans with access to very good data. Right, and you do in fact need data to execute these types of agreements. So to give you just an idea of how relatively simple but sometimes inaccessible those data are, we wanted to do an agreement with a plan whereby our requirements were basically that they have the right LDL to go on the product, that they have a pre-existing cardiac event, and that they take the drug. Right, and they were pretty confident they could determine whether someone was actually filling the prescription. But in terms of getting their baseline LDL or LDL changes, or even if they had had a prior event, right, this insurer told us that was extraordinarily, that would be difficult information to get. So I think that to answer your question, to enter in one of these agreements, we require some fairly rudimentary data. And I think as I've sort of made the point, I think in order for us to catch up to the amazing advances that some of the medicines have from a personalization standpoint, I think we're going to have to create a system where these data infrastructures are much more sort of talk to each other, let's say, because that data is out there. Most physicians now practice with some type of an EHR. Most hospital systems have a large integrated database for people in the hospital. But those systems are not yet talking to each other. Somebody mentioned, who's my doctor? Yeah. Right? I think we still have a massive who's my doctor problem in the United States.
And that's really. I mean, I think that's it. And again, the electronic health record as somebody who uses one. If you've seen one version of Epic or Cerner, you've seen one version of Epic or Cerner. I mean,
Right.
across the UCs, we all have Epic, but we don't have our structured data in any similar way and so forth. So it is a big problem. I think we need to be where the banking system is, where you can go to any ATM and use your card anywhere in the world and be able to figure it out. So I think there's a lot to go forward for that. So I think if we don't know who we're caring for in a health system, it's very hard to know how many patients who could benefit from your therapy.
So just to finish up the thought, and so I appreciate the question. I mean, one of the things that pains me a little bit when I see it, and it's just started to happen in the last month, is that people are starting to say value-based healthcare is overpromised, underdelivered, and is a failure. Right? I would actually say the concept has made people think differently about value. I think the conversations that we have are incredible, but I think we need the data to do some catch-up so that we can execute these things. So I don't think it's failed. But I think
Hasn't been tried.
Right, exactly. I think we need to keep at it and inject this into our care for patients.
So another question?
Hi, this is a question for the panel. So when it comes to data, I think there's mention about using big data and collecting this enough information to have strength for these studies. I'm focused on more of the commercialization of precision medicine. And so when it comes to ownership data, what's preventing the broad use of data? Is it like the ownership issue? Is it the IP issue where, people are afraid to share data to, in the fear of potential loss of future revenue? What is the issue behind this whole data issue?
Clara, do you want to say anything about what you've been considering?
It's a little complicated. I know that for us, in the universal consent, and by the way, anybody can look at our universal consent video. It's on the Institute of Precision Health website here at UCLA. And we were very careful when we actually developed this consent form. And ours is a little different from those at some of our partner UCs because we specifically made the case, we let them know that if there are any discoveries that come from this, that those discoveries will be the property of UCLA and its collaborators. Because that has been an issue in the past. And from an ethical perspective, this notion that, well, you're going to share my data or sell my data, my healthcare data, has been a problem. There's also this fear of, if this information gets out about me, then what about, is it going to affect my healthcare? Life insurance, disability insurance, all of that. Now, GINA, which is the Genetic, Non-Discrimination Act, it prevents companies from discriminating against you. However, with all of this data, I think most people assume that their data are out there already. Everyone's data has been hacked in one way, shape, or form. So I personally don't have an issue with that because I know that it's out there. But there are a lot of issues with respect to who's going to own the IP. And at the end of the day, a lot of companies are saying, you can keep the IP, I just want the data. But there's also this other notion that companies will put a certain financial, like a dollar amount on what the data are worth when they're going to turn around and create a product, let's say it's a drug, and it's going to be billions of dollars. So I think there are privacy concerns, certainly on behalf of the patient. I think there are IP issues, and then at the end of the day, it's also a financial discussion.
Martin?
And I'd add to that interoperability, which is just basically getting data structures to talk to each other is a formidable barrier. I'd also suggest that missing data is a problem because everyone I don't know who analyzes data for either a living or as a hobby. Right? Everyone knows that it only takes a missing rate of data. Particularly when you're answering questions where you want a fairly precision answer. Once you're missing 10 or 15% of the data, the answers you get from that data are highly suspect. And so when we go and look at, for instance, EMRs, from physicians, a lot of the fields are blank. Right? A lot of the fields are not filled out, and some of the fields that are filled out just so they can sort of get through it, so they can click to the next screen. So I think between all those issues, I think we're still sort of not to a point where big data is, if anything, I think big data is maybe not living up to the promise of what it was 5 years ago.
Jack?
I'm Jack Needleman. I'm chair of the Department of Health Policy and Management here at the school, Fielding School. I'm having trouble imagining how this actually rolls out in any efficient way. I think about the BRCA genes and how first somebody had to identify that the BRCA was associated with an increased risk of cancer. And then we have a test, so we can now test you and make some judgment about your relative risk and the relative risk for your children or your sisters or sisters. And that took a while. So I hear Martin talk about, the possibility of finding the drug that will work for you. So antidepressants work, any given drug works for only 40% of the folks. So where does the data come that enable us to assess which drugs are working for which patients, and then which genes are associated with that, so we have the markers that we can then test? And then we turn around, what kind of testing are we going to expect somebody with depression to have in order to decide what drug they're going to get? There are massive data issues here and sequencing of analysis looking for lots of needles in lots of haystacks. And how does this play out in the real world in terms of looking for a genetic association with either a treatment or a disease, and then in turn figuring out how that translates into treatment information?
So I can address that at least for the pediatric cancer setting. The difference between pediatrics, most children with cancer right now are enrolled in a clinical trial. And the clinical trials have evolved over time instead of just testing a drug based on some laboratory studies to having a very strong biology component. And so when the biopsy is taken, when there are bone marrow biopsies taken for leukemia, there is as much biology done on that sample as the assessment of how that child is doing, from whether they have metastatic disease, et cetera, the sort of demographics. And so the move really for clinical trials in cancer now is really focused on identifying patients based on their genetic profile, for example, and trying to find drugs that will be, targetable. The problem is that the genetics has advanced much faster than the drugs have been developed to treat them, and so it may take 10 years to get a drug to market, whereas the biology, the genetics of cancer has moved tremendously in the last 2 years, 1 year. And so I think the goal is to get adults enrolled in more clinical trials where you have the same data collected in a more controlled way. I think for pharmacogenomics, using depression as an example, as we identify more risk factors or more susceptibility or more drug targets, so when you come in to see your psychiatrist, you're going to get a genetic screen. And they're going to be able to say, let's try this drug first, as opposed to just successive ones that don't work. And so I think the testing is actually moving along much faster than the availability of the specific drugs used to treat this disease.
And if I can add, I think that what we're trying to do is, so actually, I wasn't surprised by Martin's 10 years to bring a drug to market. That pretty much is what in fact, that's on the low end, what it takes to bring a drug to market.
This was it was a diagnostic test, though, to go with the drug, not the drug.
The companion.
The drug probably took 10 years too.
By itself,
So 10 years for the drug and 10 years for
The drug might have taken longer.
Yeah, even longer than the companion diagnostic. But what we're trying to think about is so technology has certainly moved us down. I mean, it's developing on steroids. I mean, every day, every week, 10 new tests are available. And all these companies are constantly developing new tests. So our genetic counselors can hardly keep track of them. I think what we're trying to do, the whole goal is to accelerate the pace. And this notion of interoperability, I mean, you're dealing with an electronic health record, which is a beast of burden. It is basically focused on how we can get paid. And so physicians are, I mean, yes, it does hold a lot of information. Yes, it's got lots and lots of holes. I think the key is to start, the more we can create infrastructure to collect things systematically and use the technology to our advantage and start getting this, creating that learning healthcare system. So you identify the patients, you collect the data, you analyze the data, you start then starting to make, clinicians can start weighing in on what that might look like, or what this might mean, and then roll it right back and create it into for example, a clinical decision support tool. That is the goal. However, I don't want to give you even more bad news, but really what we're talking about here is going to be, for us at UCLA, at least 5 years of intensive research and data gathering to be able to get to the point where we have enough information and we fine-tuned this cycle to be able to start thinking about how we can start to develop these decision support tools. So I know that in some areas, cancer is the leader in precision health, absolutely for sure. But how we can keep track of all this, unless we have a coordinated system, that these systems that are interoperable, being able to get data systematically out of the EHR, figuring out how to clean this up. A lot of people are trying to go after notes. Well, I have to tell you that notes really are devoid of substance. Sometimes even some of the diagnoses in there are just not, they don't apply to the person. The resident forgot to erase that part and put in the new diagnostic code. So, however, is there value in looking at, remember, the body is a source of big data. Being able to look at and integrate information from radiology, from genetics, from all sorts of different sources of information. That's where I think, because of technology, we can start crunching machine learning algorithms. We can start, I mean, this notion that Watson was able to diagnose, was able to learn everything there is to know about medicine in terms of the medical school curriculum. It digested it in, I don't know, 10 minutes. And then reading papers. And then at the end of the day, it was able to make the same diagnosis as some very seasoned clinicians. It's scary because I'd rather have a clinician at the end of the day who's seen 1,000 patients with the same thing. That's what you get when you go to a children's hospital that you don't get from going to just a regular hospital, is that you have clinicians and specialists that have seen this in children a million times. So as we start thinking about what technology can do to help us make this go faster and create a more cohesive system, I think that's going to help us. Now, I also think we're going to have to change the conversation, because the healthcare system as designed right now is not designed to sustain something like this. It can very easily go bankrupt. So there's so much more, and being able to bring together public health, the business school, folks on the health law side, on the policy side, in addition to, there are lots of people that have to be involved in this conversation to make it move more smoothly.
So I just wanted to just say one thing. You know, I think the missing data issue is a very important problem. And Jack, I think we'll still need to have research studies where the data are very well curated, where somebody's getting a comprehensive look, and then that can be translated into larger population studies. But I kind of see the learning health system more as a data mining operation and discovery, where you didn't expect something, but you do find an association by chance, which you didn't expect, or you look for patterns and see if they're replicated from the trials. But I also wanted to say I had an interaction last week with someone, a professional at another university who I had met at a conference, and she had a very strong history of breast cancer, both on her father's and mother's side. Actually, her father had had breast cancer, her grandmother had had breast cancer. She had breast cancer at 48. And her mother had had ovarian cancer. So I said, did you have genetic testing? And she said, yes, I was BRCA negative. And I said, oh, did you know that we have panels now of more genes that can cause breast cancer that are familial than not? And so this was June I saw her. She sends me an email, please talk to me about this. It turned out she had a PALB2 lesion, which is in, again, the DNA repair pathway, and that is causing her breast cancer, clearly. And so now, you know, there's a much different conversation about this. She wasn't going to get breast cancer surveillance. She has lumpectomy, so she has 2 breasts that are left. Her doctors weren't going to do surveillance because she didn't have a high-risk genetic profile. Now she does. Other decisions can be made. So what I want to say is, at the point of care, if you don't have providers who are knowledgeable about doing these kinds of things, it then falls apart, and I think that's where the healthcare system has to do a better job educating people from medical school onwards, because there are not going to be enough genetic counselors to handle all of the problems. We need to have this throughout the system, and we need to educate the public about it so that the patient can come in and ask, did you test my tumor? Did you test my family? Et cetera, et cetera. Yes?
Eric Wilkes with the Fielding School. Ironically, there was a story today on NPR. A couple of you touched upon underrepresented communities, and the story was regarding a study back east somewhere, I think, where they were trying to collect as much diverse information from a diverse community, and they were going into churches to try to recruit African Americans to participate. And obviously, they interviewed older people who clearly identified it, Henrietta Lacks, whose, of course, cells are used without her acceptance, and, of course, Tuskegee. But they also interviewed people of younger generation who say, my friends are still posting on Facebook every other day about Tuskegee. What sort of challenges are you aware of or have you heard of, and what are the solutions that you're trying to employ to try to convince people to participate when there's still such resistance in communities like that?
And that's huge.
Yeah, I think for us, where we are, so we have a very diverse population at CHLA. We have a very large Hispanic population, Asian population, and when we're actually doing our genetic testing, when you actually look at the DNA sequence, it's obviously influenced by your ancestors, and so it's important to know if we have an alteration that's present at a very high rate in a child of Hispanic origin. It may not have the same implications as somebody who's of Asian descent. And so it's really important that we get all those patients enrolled. And so we actually contribute data to national databases because it's really important that all of these different racial and ethnic groups are represented. We, right now, because all of our testing is really essentially supported by the hospital, we don't deny anybody testing if they can't pay. And again, I don't think that's sustainable. I think, obviously we won't talk about politics, but I don't know what to say. Yeah, so I don't think, we have translators, there are consent form in a couple languages, and so again, in a pediatric setting in oncology as well, they really make an effort to enroll everybody in clinical trials, regardless of their background.
And I think I've done a lot of work with underrepresented minorities, and I think the conversation needs to shift. I've done a lot of work with the Latino community, and the key there is trust, because there's legitimate distrust that's out there, especially in African American communities, also the Latino community. And the way that I think we need to shift the conversation is to have more of a discussion that is around, well, all of our reference standards for genetics are based on Northern Europeans. And so if that's your reference, then there are certain things, mutations that might be disease-causing or pathogenic in one group that may not be pathogenic in another. And having that information is really important. And being able to say, let me tell you why this is important. A colleague of mine here, Carol Watson, she's involved in cardiovascular medicine, and I'll tell her story because I think it's incredibly relevant to precision health. She is focused on, obviously, heart health and cardiovascular medicine, and all of their reference standards are based on the 175-pound white chubby man. And early on, they thought, well, let's just do research. They say an aspirin, give everyone an aspirin and it'll prevent the risk of stroke. Well, all of a sudden, they started to realize that when they started collecting data, they started to see that there were some medicines where, or aspirin specifically, it would reduce stroke in men, but it had no effect in women. And then when they looked further, they realized that, well, it was heart attacks. It was heart attacks that it reduced the risk of a heart attack in men, but not women were unaffected. but it reduced the risk of stroke in women. And actually, when you looked at men, they actually were at increased risk for stroke. So all of a sudden, they're starting to realize that women aren't just, smaller men. And so the thought of actually looking at the effects of certain medicines and the impact on women was novel. And when they started to do that, one of the things that she's realized, for example, is that the risk for diabetes can be very different between men and women. Carb intake for women is actually much more deleterious than it is on men and heart health. So when you start thinking about that and actually speak to communities in ways that they can understand impact what are the impacts on their health, I think we have to deal with that issue of trust. And I think that a lot of underrepresented minorities, they don't get tested because either it costs too much money, their insurance companies won't pay for it, or there's certain stigma around it. And quite frankly, there are there aren't enough geneticists that are working with underrepresented minorities, so we need to do more to actually improve that. And we've been working with some of our colleagues here at Drew who are developing really interesting and novel ways to actually increase the workforce in some of these key areas, because it has to come from within communities also. And so I think that's the part of the conversation that perhaps needs to shift.
I heard a great suggestion, a way forward. I don't know who's heard of Lee Newcomer, but Lee Newcomer is basically the ecology director at a major insurer, United Healthcare, and this is related to, how do you kind of move the needle? And he had a radical notion. He's like, wow, oncology care is becoming incredibly, sort of challenging, complicated, and also resource intensive. So why aren't we getting a standardized data set on everybody who has cancer in this country? It can be de-identified, it doesn't have to be personalized, but what if we were to take a high cost, high sort of morbidity area like cancer and then basically collect data on everyone, but not only that, but feed data back to people, right? Tell them, reflect them versus population, publish on it, everything, get people comfortable with this idea of collecting and talking about the data, right? And that would probably begin to bleed over into clinical trial enrollment and other things. So I think it's involving people. It's basically treating them like people rather than like numbers, right?
And demystifying the conversation is really very important.
Exactly.
That notion of trust, it needs to, I feel strongly that it needs to come from within.
Hi, Aninda Das. I'm a clinical, I'm a practicing pediatrician. The question is for Dr. Beagle. Where do we stand on expanded newborn screening in the context of everything moving really fast, but we have no real treatment for a lot of these things? I just wanted to know from a really health policy and ethical perspective, where do we stand on newborn screening and its expansion?
So expanding from mostly metabolic screening to more genetic disease-based screening?
Right, yes.
It's a good question. I think the problem is so many of these diseases are rare. There may be 10 or 20 patients, born in the state of California with any one particular rare disease. And so how do you justify the economics there I think is really the issue. So there's a genetic disorder called DiGeorge syndrome, or cardiofacial syndrome, that's due to a small chromosome deletion. It's the most common genetic disorder. And there's a lot of discussion about adding that to the newborn screen, and it hasn't happened. Even though it's still several $100s just for that test alone. And most of the newborn screening is really dollars per test. So I think it's a cost-benefit ratio right now.
Has there been any genomic move to do whole sequencing rather to cut down the cost of it, or it's the interpretation?
No, I mean, it's just too expensive.
Too expensive.
To do it on a large scale like that. And you really need to do that in a very strict consenting process, which most families don't even
At that
know
point in
that
time,
newborn
yes.
screening is
Yeah,
happening.
yeah.
Unless you
Yeah.
get an abnormal result back.
Yeah. Good.
I'm a family physician in East Los Angeles, so I was pleased to hear about the diversity of the patients being involved. So I'm excited about precision medicine. As a family physician, I'm looking at sort of what role we will play in that. I appreciated Dr. Ganz's introduction about that. I'm also a free market guy, and I'm all in favor of people being paid fair wages. But there's also the challenge we're going to have, which is how much is fair compensation and where does it get to become greed, right? And one of the challenges we have with new treatment modalities is they get to be very expensive, and then we're asking insurance companies to pay, and we badmouth them because we say they refuse to pay, and they push back and say, well, the evidence doesn't show that it should be supported, and it goes back and forth. We talk a lot about value, and all of us are self-centered, and we say, I'm so valuable that I deserve more money. So everyone comes in to that equation expecting to be paid more money. And so my question is this: there's an emerging science, there's the Clinical Effectiveness Research Institute, the California Technology Assessment Forum, that says, let's really get to what true value is with new modalities of treatment and set a price that is fair to the developer because they have R&D costs and all the other things, but it's also fair to the consumer who has to pay for this either through taxes or through their own pocket. What role do you see academic medical centers, the pharma industry, the health insurance companies doing to work together to come up with a true value-based definition and methodology?
Wow, I guess that's for me.
It had dollar signs attached to it.
Yeah, exactly.
Yeah, because I'm going to have to head back to Cuba for that one.
So that's I'm going to call that out as a multifaceted question in a rapidly moving area. But let me talk a little bit about the assessment of value. I think the slide that I probably put up there that most spoke to, just sort of it's the man and the elephant analogy, right? Someone touches the trunk and it feels like a snake. Someone touches the leg and it feels like a tree, et cetera, et cetera. I don't think we've actually come up with in this country a reasonable definition, or I shouldn't say a reasonable definition, a standardized definition of value that we can kind of agree on. To me, value is trying to anticipate how a product can and should be used and in whom, right? And essentially trying to project that use, to encourage that use, right? And then to measure all of the costs and benefits associated with it. And that's why I put the two slides up I put up. If the expectations of how many people are going to get a drug are hugely different between insurers and patients and physicians and the manufacturers. That was the first slide with the yellow bars that were 80 times what the expected uptake was. And if the publications are all publishing a different notion of value based on a whole different set of assumptions, right? In this case, well, we think a lot less severe patients will get the drug. People are only having 2 or 3 events a year on average. It's 2 out of 100. That's a relatively low frequency of events. If we can't agree on those tenets, right, and the way we do those analyses, we're just going to be talking past each other for a long time. So I think one word captures to me what I think absolutely has to happen with these assessments. I think they need to be fully transparent, all the assumptions. There actually is one group now, the Institute for Value, IVI. It's actually run by kind of a local Darius Lakawala, I think from USC, so, and some folks over there. But their idea is to make this open source. Right? Their idea is to put everything, all their assumptions on the web, right, so that anyone can see the assumptions that are being made, right? Because I think, hopefully my slides convince you, the assumptions are so important. So I think once we have those assumptions out in the open, then we can have an adult dialogue, right? About, well, would this drug be used in someone who has 3 events a year or 10 events a year, right? We can actually go to payer databases, and we have done this. And we've basically said, if you were to allow this type of patient with these characteristics, unrestricted access to the product without all the barriers, you would basically likely see a population that would have 10 events a year, right? And we would even be willing to go at risk you didn't see those 10 events, if it were only 7 events or something like that. So I think, again, I think we have to have, it starts, I think, with transparency and adult dialogue, and then I think it moves from there. But right now, people are just shouting at each other, which is kind of a shame, because I think that we have the data, and I think we have the ability to have a much more joined-up conversation, and that's what we're trying hard to do now.
Yeah, and I was participating in a community advisory board for, as a professional stakeholder for a pharma company, and they came to us and they said, we want to do this study, and it was going to be targeting kids with autism. And when we were asking them about, well, what was your primary outcome measure, and they laid out one or two that it could be, and they said, and I said, well, what do the data look like? What kind of effect will it have? And it was the most minimal effect I've ever seen for a particular drug. And they said, well, and I said, well, and others, well, how much is it going to cost? Astronomical, like $70,000 a year. And you're talking about a group of patients parents who are desperate, and kids where everyone's trying to find a magic bullet. And it's, so you mean to tell me that, and the toxicity, the profile was pretty bad. So the side effects were potentially really debilitating. It cost a lot of money, and the effect was going to be minimal. And I thought, why are we here? Why are we at the table? And yet they were really wanting to engage us, a bunch of different stakeholders, to ask the question about whether they should pursue this. And I said, well, ask yourself, would you put your child on this drug? And they sort of kind of looked at me and like, well, and they couldn't answer the question. And so, you know, in this case, this particular company came and they really did want feedback. They did not move forward with that trial. But at the end of the day, these are the kinds of questions that we need to hold everyone accountable for. And then Pharma Bro, he didn't do so well. And that was just poor, you know, greed. And I don't know how those things actually get that out of control. But again, I think that it's going to take a lot more right now. And we need to be framing, there needs to be a paradigm shift, a cognitive paradigm shift that brings together the business people with clinicians and the drug companies to actually come up with a solution. Everyone wants to, you want to do well by doing good, but you also have to make money. So how do you reconcile those two things?
In the back over there?
Hi, my name is Katie Hobson. I live here in Los Angeles. I've worked with physicians for many years. In the past few years, with this wonderful topic of genetic screening, and I wanted to make mention of something that this gentleman up front had mentioned earlier, and just kind of ground level it, working with physicians and their focus on using precision medicine. It's an interesting study with all the years I've been involved in this, is that the importance of education is really key to help them understand where this fits in their practice, how it fits in their practice. But I will say that physicians that take the time to figure that out and apply it to their patient types, particularly cardiovascular, pain, or psychiatry are sort of the biggies, there is a lot of benefit, and something that people here may or may not know, because there's a nice mix of variety of people here on all sides of the court, if you will, that the idea is for the test to help identify what would be most beneficial for that individual based on their genetics. And I've seen personally a lot of benefit from that. This test is, once you do it once, it's good for life, just sort of like a person's blood work, if you will. So on that note, I just wanted to make mention of that. But one thing I would like to ask is, with all things said and high and every level out there, where do you prioritize this with the physicians at hand, and how do you get them to just get started?
So, having a relatively new molecular genetics effort at CHLA in the last couple of years, we've really seen the spectrum of physicians who are very eager to learn, who are very sophisticated, and those who really don't know anything about genetics and really reach out. And I think part of our mission, even as a diagnostic lab, is really education. And what we've seen, either, based at USC, the medical school curriculum is really woefully lacking. And so just us being there and being a host for medical students and fellows and residents, it's a good beginning. You know, it's like you want to get the kids when they're in kindergarten. It's the same kind of thing. We can at least start with medical school. I think it's just that, you know, they're seeing things in the press, but when you have an individual patient and you're working with that physician, it doesn't take a lot. It's one good experience that will really sort of make them less uncomfortable with the whole process. And so I think a lot of it is just really education and finding out how best to do that and do that. I think that's a big role for genetic counselors too. And so it's not just working with the individual patients, but it's also working with the medical providers.
I'm a clinical lab scientist. So in academia now, I feel there, like you said, there's a lack of probably students and what they've gone into. What in the future, do we need different degrees? Do we need another degree called something else? What, because the integration that needs to take place, what would be the most helpful that the students would go into?
Right, good question. So, you know, in the past, traditionally, there's been a fellowship in clinical genetics, medical genetics, that physicians will do, and then the PhDs have really been more on the diagnostic side. They started because there's such a shortage of clinical geneticists that they combine their residency and fellowship program, and so you can fast track. You know, some of the feedback that we've seen is just the reality of once you have to pay for medical school, genetics is one of those services where you don't get reimbursed, and so they don't get paid very well. They can't pay back their student loans. So it's just the reality of, you know, what they might be interested in it, but they make a decision that they really can't afford to be in that field. And that's just sort of tragic. And so I think the alternative is you incorporate genetics into every field, every subspecialty, that has, you know, more intense training in the genetic aspects of that disease. And I think that's a two-pronged approach. Encourage people to get into genetics because it is a really important field, but make that education be so critical. I think we're seeing new programs even in the bioinformatics side, so a clinical bioinformatics training. So USC is starting a new master's program next year to really train, you know, the data analysts, the people who work side by side with the laboratory folks in a very clinically oriented area.
One of the things that we're doing here at UCLA is we are, to basically follow up on Jacqueline's excellent point, is we're trying to create a clinical division of a division of clinical genetics here, where we're going to be making sure that there's somebody with expertise in genetics, in neurology, in cardiology, in pediatrics, and in all of the relevant disciplines. So then you're starting to have a center that has the expertise, that's the subspecialty expertise, and they then can go and begin to educate their colleagues about genetics, genomics, because it really is, a lot of physicians just don't even want to go there. They don't want to order the test because they don't know what to do with it. Neurogenetics might have a wait list that's like really, really long, and so there's a certain fear of actually even going there. So I think the education, we can't just talk about the education, we really need to think about how to be clever and embedding that education. Medical school, certainly, there are so many things that I'd put into a medical school curriculum right now that it'd probably take another 3 years. But I think it's being more strategic with how you start to think about genetics. Because if in fact it's going to become quickly the wave of the future, then everyone's going to have to start thinking about how they can do this responsibly.
There's also, I was just going to also say that there's also the issue of people who are 20 years out from medical school who will have to learn these things, and thinking of the KRAS experiment there, it took about 2.5, 3 years before it diffused through the oncology community, even when you publicize this, because learning new things as a clinician is time-consuming. So I think that's the issue. And the pharmaceutical companies actually do a pretty good job of direct-to-consumer marketing to physicians to educate them about these things.
I just want to actually answer his question. Things. My name is Eva McGee, and I'm on the faculty at Charles Drew as well as UCSF. And I just want to say a good model university for working with the underserved communities is actually the Johns Hopkins. And even though what happened to Henrietta Lacks actually happened at the Johns Hopkins, but they are doing an amazing job at actually pulling in, for sure, African Americans into the precision medicine studies. And there's a little town called, it's called Turner Station. And they have a big cervical cancer, prostate cancer, educational session there every year. So, and like 1,500, 2,000 people show up for this educational session. I just thought I would throw that in.
I think that's a great note to end on. I want to thank all of you for coming. I especially want to thank our panelists and our moderator. The next Health Forum is the last Wednesday in November, so I hope to see you all on November 29th. Thanks.